welcome to the Journal of Oncology Practice podcast. I'm Dr. Bob Miller from Johns Hopkins. In the March issue of the JOP, we published the 2013 update of the ASCO ONS Chemotherapy Administration Safety Standards with a focus on the safe administration and management of oral chemotherapy. Here to give us some more information are two of the primary authors of the paper. Martha Polovich is an oncology nurse who has experience in inpatient, outpatient, and home hospice environments, and she has a special interest and expertise in chemotherapy administration. She was a co-author of the original 2009 ASCO ONS Chemo Administration Safety Standards and the subsequent two revisions in 2011 and 2013. And welcome, Marty.
Thank you so much for having me.
Also with us is Mike Neuss, who is a medical oncologist and the chief medical officer at the Vanderbilt Cancer Center. Mike is the current chair of the COPE Steering Committee and chair-elect of the ASCO Quality of Care Committee. And also welcome to you, Mike.
Thanks, Bob. It's great to be here.
So I want to talk to you a little bit about the background of these ASCO ONS safety standards. I know they were published initially in 2009 and 2011. Can you tell me a little bit about why this was undertaken in the first place, and who was the intended audience of this safety standard?
Well, ASCO approached the Oncology Nursing Society in 2008, interested in developing standards together, and they were focusing on safely delivering chemotherapy. So ONS has had guidelines focusing on safety for many years, and ASCO recognized that as important and so approached the ONS to work together. Both organizations represent the practitioners that are responsible for administering chemo, and so it made sense for the two groups to collaborate on this project. And indeed, it also supports the mission of both organizations. So with the help of other interested stakeholders, such as pharmacists and even some patient advocates, the standards were developed in 2009. And then updated in 2011 and 2013. And the intended audience for the standards are oncology practitioners who treat patients with anti-neoplastic agents. So that would be physicians and nurses, and also organizations where treatment is delivered. So practice administrators are an intended audience for the standards as well. So originally, the standards addressed outpatient chemo administration, and that was extended to inpatient in the 2011 standards.
And did each standard stand by itself? Is each revision a standalone document, if you will?
That's kind of challenging to discuss. The standards were changed in 2011, but the changes were incorporated into the original standards and updated. So they don't really stand alone. They were built on one another.
I see. So talk a little bit about the 2013 revision. Why was it felt to be important to focus on oral chemotherapy in particular right at this time?
Well, when the standards were developed, ONS and ASCO both recognized that there would be a need for periodic updating of the standards because practice changes over time. And after the 2011 updates, the steering committee and actually all the participants in the process recognized that the current standards didn't really adequately address safety for oral anti-neoplastic agents. And so when the 2011 update was done, it was already planned to focus on oral agents in future revisions. And that's mostly because patients on oral agents often are managing their own therapy at home. Oral agents are also administered by non-oncology nurses in hospitals and clinics. And many times, patients are receiving oral agents in places like nursing homes that aren't usually involved in chemo administration. So the oversight of oral therapies is really challenging, and that's why the focus on these standards at this time.
Let me ask Mike, can you talk a little bit about the scope of the oral agents that were considered for this standard? Are we only talking about cytotoxics, or are there other classes of agents included?
Well, it turns out that when you start to think about things very carefully in terms of developing standards in particular, one realizes that words that have been taken for granted, like the word chemotherapy, don't have as explicit and constrained a definition as you would like. So your question is absolutely on point. We, for the purposes of this update, defined chemotherapy as being any pharmacologic agent that was used to treat cancer, and for the standards, which include both oral and parenteral agents, given through either route. We did include both cytotoxic antineoplastics, the first example of that being nitrogen mustard, and we also included newer agents such as kinase inhibitors and other drugs that were given not to kill all cells and kill cells indiscriminately, but targeted therapies were included as well. And some biologic therapies, such as interferon, were included as well. Hormonal therapy, which are very important in the treatment of cancer, are not included in the definition of chemotherapy for this paper, although, of course, we all recognize that hormonal agents are very important in the armamentarium of treating cancer.
Can you talk about the process that the steering group went through to put together the standards? So was this based on a literature review, or was it more of a consensus-based process, say like the NCCN does?
Well, wouldn't it be nice if there were a literature for everything we did?
Right.
You can tell this is not a randomized clinical trial-based literature. If you think of just one of the most basic standards we've included here, that is that the patient should consent to chemotherapy, I don't think there ever was or will be a randomized trial that shows how that influences the outcome, though it's clearly something important. So we looked at existing standards in the area as they existed from organizations such as the Joint Commission. We looked at the evidence as it existed, and there's very little discrete evidence that doing the things we've recommended, such as having a plan to begin chemotherapy before you begin chemotherapy, though ASCO has a guideline for treatment planning and treatment summaries, there's clearly no evidence that influences the outcome. So we looked at the literature, and where there was literature, we incorporated it in our standards. We looked at consensus-based face value measures or standards that would make sense, such as obtaining the patient's consent. We looked at legal standards, although not exhaustively. We have a standard that drugs be prepared in a manner consistent with local regulations and Board of Health and other state laws. But basically, we started with what evidence there was. We built recommendations based on the consensus of the group. We then posted the comments for public comment, which we felt were very important in developing the standards. We reconvened a group of experts to go through the measures again and incorporate public comments as to the feasibility of the measures and the value of the measures into developing a final measure set that was then approved by both the boards of the ASCO and the Oncology Nursing Society before they were published.
I want to ask you about some of the specific standards that are in Table 4. So for the listeners, if you look on page 8S in the March issue where this is published, the entirety of the standards is listed there, and it's about 4.5 pages long, so it's very, very thorough. Can either one of you talk a little bit about the ones in particular that relate to oral chemotherapy safety? What things do you think are important to highlight?
Well, for instance, Standard 8 addresses safe storage in practices that have dispensing pharmacies for oral agents. Now, that's not every practice, but it's an important aspect of managing oral agents. Number 9, I think, is a really important standard because it addresses safe communication about dose changes for oral agents. Because when dose changes happen with IV chemotherapy, for instance, that's communicated directly to the practitioner who will be administering it. Many times patients are on oral agents in the home, and they may be reporting to the physician, and the physician may be calling them back because of side effects and recommend dose changes or schedule changes based on that communication with the patient. And that process of communicating is really important so that it gets in the patient's medical record. So that is a new standard. Talking to patients about when drugs should be discontinued is an important standard. Number 14 addresses that. There's also number 20, a standard that requires patient education be provided in writing for oral agents. And then the next one goes over the need for independent double checks for oral agents when they're administered by a healthcare worker, such as a nurse. And that is the same process that the standards require for IV chemotherapy. But in many organizations, the process for IV and oral are really quite different.
So it sounds like for the oral administered meds in the home setting, you wouldn't have that same safeguard. I assume there's not a way in the clinic, since the drugs are not often dispensed in the clinic setting, or were you envisioning some other sort of double check process?
If I can interject, I think in Standard 2, we address some of these issues, such as Standard 2I, which says before initiation of an oral chemotherapy regimen, assessment of the patient's ability to obtain and take the medication according to the treatment plan is verified. I think it's very different to give a patient a prescription for medication. Additionally, within Standard 2, we talk about the patient coming back to the office. You know, if you give somebody CHOP in the office to treat a lymphoma, they aren't going to get a second cycle of medication without coming back to you. On the other hand, if you give a patient a prescription for thalidomide, with thalidomide, because the REMS, you can't give multiple refills, but you can give multiple refills for a drug like chlorambucil. And if the patient is supposed to take 4 days of chlorambucil and after 4 days just gets their prescription refilled because you thought it would make things easier next month, they can get it refilled and take too much medication. So you also have to have a different level of attention to the details of how the patient continues on treatment and how they come in for follow-up so that they don't get too much or too little drug.
What about prescriber qualifications? I think that was addressed in Standard 1A. It reads, the orders must be signed by licensed independent practitioners who are determined to be qualified by the practice/institution according to the practices or institutional policies, procedures, or guidelines. So does that speak to the issue of non-oncologists who prescribe some of these medications?
This has been one of the more controversial issues because there are some anti-neoplastic medications that are prescribed by non-oncologists.
Sure.
And there's some transplant rejection suppression drugs that are now used as anti-neoplastics. So I think we're somewhat agnostic on the question of how these qualifications are determined to order anti-neoplastic medication. But we do say the institution can make its own rules about how you do that. For me here, we have lots of people giving cyclophosphamide and other anti-neoplastics who are not oncologists. It happens most in neurology, but it's happening also in rheumatology and has been for a long time. So I think these standards apply to any practitioner, not just an oncologist.
How about a non-oncologist prescribing these oral drugs for oncologic indications? I guess I was thinking of like a urologist that might prescribe a TKI. Does that sort of fall under the same rubric of Standard 1A?
I think it does.
Okay. What about the pharmacists? I know in my previous practice when I was in California, you'd always get nervous when you'd write a prescription for capecitabine because you never knew if the pharmacy had any experience in filling it or dispensing it, or some of the instructions that go on the bottle, which seem to be all over the place. Do the standards address this issue of pharmacy or pharmacist competencies in the dispensing process?
That's a great question, and another area that was very controversial in developing this. In the end, simply put, we decided that state law governed pharmacy dispensing rules and that we could not venture into this territory very easily. So we are silent on pharmacist competency, assuming that if the medication is prescribed correctly, it will be dispensed correctly, and really leaving our faith in the prescribing process and less so in the dispensing process. And that was very controversial.
Were there pharmacists that were part of the steering group who helped craft the standards?
There were pharmacists who were part of the steering group, and they had much stronger feelings about regulating pharmacist practice related to anti-neoplastic therapy. But we focused on organizations where this was a usual thing, such as a hospital or clinic that was in the business of managing anti-neoplastic therapy, realizing that a lot of these drugs might be prepared in retail pharmacy where the safeguards might not be followed.
So let me ask Marty, can you talk a little bit about Standard 25, which discusses the concept of patient adherence to an oral chemo regimen? The question I always have is how can you really measure this effectively in the home setting?
Well, I think that assessing adherence is one of the most challenging problems that we have related to oral agents. Again, with IV therapy, that's really easy. The patient comes for therapy and they get their treatment while they're there. There are lots of studies that disagree about the most effective ways to measure adherence. And truly, most of them, such as pill counting or electronic monitoring, have only been used so far to measure adherence in clinical trials. So some of the ways that might be effective are, did the patient fill the prescription on time, or did they indeed fill it at all? And the most common way is just asking the patient how they're taking their drugs. But any one of the ways of measuring adherence is really kind of problematic. But the standard doesn't really address the best way to measure adherence, but it does encourage organizations to develop a plan, at least for initial assessment of adherence and then ongoing assessment.
I think Mike may have addressed this earlier, but one of the concerns, of course, with the cost of these agents is whether patients can afford them and whether you're giving them a prescription only to find out that they go to the pharmacy and find that they have a $3,000 copay or something like that. Was that sort of barrier, was that embedded within the standards document?
As I mentioned earlier, I think the necessity of confirming that the patient actually can get the medication before they get it, and addressing the issue and addressing specifically that this is a lot more than just writing a prescription and passing it to the patient across an examining table is explicitly addressed within the standards and thought to be a necessary part of prescribing oral chemotherapy. I would only say, in addition to that, as we've demonstrated here in the practice that I'm part of, patients leaving the hospital who have drugs prescribed to keep their stents open don't get those prescriptions filled because of the cost either. And I think in oncology, these things are a little more clearly brought to the surface because of the perhaps magnitude of some of the costs. But these are issues that are universal to patients who are given any prescription that they have to pay any amount of money for. Sometimes they just can't do it. And part of being a good physician incorporated in these standards is to just make sure your patients really are getting and taking their medications.
It seems like such a moving target too, because sometimes the copay for the first month is $3,000 and then they meet their deductible and then they don't have any copay for a while or it's a much smaller number. And then before the prescriber realizes it's the end of the calendar year and the copay starts all over again. And so I think it must be really challenging for many smaller practices in particular to sort of keep track of things.
I think you're absolutely right, and it's hard for the patients who I've learned recently have the expectation whenever you're prescribing these medications that it'll be a temporary thing. And for my lung cancer patients on crizotinib or erlotinib, and I tell them how high the cost is going to be the first month, they say, well, I'll be finished with it after this prescription, right? And you're exactly right. It's a recurring issue.
I want to ask a little bit about the ASCO COPI program, which I know Mike has been very involved with over the years. Were these standards in any way part of COPI, or did they inform some of the COPI guidelines, or is that any of the future planning?
Bob, that's a great question, and the standards are very important to the COPI certification program, which is an outgrowth of the Quality Oncology Practice Initiative quality measurement itself. We now go into practices with their permission and invitation and certify that they are adherent to these standards, these safe administration of chemotherapy standards, and also that they've achieved a certain threshold performance on their COPI measures. When practices are certified, they have an on-site audit by a nurse who verifies that the chemotherapy administration standards are compliant with these standards. And with COPI certification, some practices have enjoyed a different rate of payment from their payers, and I think all practices have been able to benefit from the standards availability to help guide them in therapy. Now, some practices have achieved perfect compliance with the standards with seemingly very little in the way of practice change. Others have had to really beef things up quite a bit to meet the standards, but I think in all cases, patients have benefited.
I know about a year ago, we talked to Terry Mulvey on this podcast. I guess it was 2 years ago is when the 2011 version came out. And I remember her saying that what she saw in some practices she was familiar with is that there was a lot of enthusiasm the first year. Everyone worked real hard to meet these guidelines. And it was very easy for slippage, as time went on. These are some very strict things and not necessarily, conducive to economic viability of many practices because they involve more personnel and more time and whatnot. I don't know if either one of you have any insights into that in the practice situations that you're familiar with.
I think we all talk about COPI fatigue and that practices get tired of doing these things after time. Fortunately, in some states, payers are recognizing the effort that goes into adherence to these measures and these standards and are actually paying a premium for practices that have gone to the trouble of being certified. And it's been one thing that has helped support the program in those practices and support independent practices who make the effort to, if you will, jump through all these hoops to get certified, with the certification being based on these chemotherapy administration standards. Unfortunately, I can't talk about the specifics of how much people are getting and in which states because we've been advised by our lawyers that ASCO as an organization can't engage in dissemination of the information of just exactly how this is working. But I would encourage everyone to talk to their peers because there are some payers that really recognize this very generously.
Marty, do you have any observations from your work in terms of practice adherence and adoption and sort of ultimate effectiveness of these types of standards?
I think that it's really challenging for practices to implement some of the standards, and mainly not because they don't want to do a good job in taking care of patients. It's that most chemotherapy settings really are set up to administer parenteral therapies or therapies where the patient comes in, gets their treatment, and goes home. And so to think about oral agents and managing that when the patients are not coming in as frequently really can be a burden for the practice, because it means someone has to pay attention to that care. Someone has to know when that patient gets that prescription besides the provider who writes that prescription. It has to be communicated. Patient education is so important for oral agents, and those services are not reimbursable often by payers. And so it really can be a burden. So practices have to think about how they're going to build these changes into practice so that we can provide the safe care for these patients.
I think one of the most interesting things I learned in this process was that 1.5% of commercial insurance beneficiaries get some form of chemotherapy in a year. And of those, about 1 in 6 are getting oral chemotherapy, or were 2 or 3 years ago, and that this obviously is going to grow, with it projected to increase to 25% of patients over the next few years. I think that tells us how important this is, and yet all of us who've prescribed this or been involved in the administration of oral chemotherapy know just how hard it is for patients to get it, understand what to do, and understand what to do with their unused medication, and how to manage their toxicities as they're on these agents that people take to be very easy to take and give, but turn out to have lots of side effects.
So what are the future plans for this set of standards? Is there another revision that's planned sometime in the next few years?
I'll be curious if Marty agrees, but I think part of our process is to review these periodically and make sure that no new information has come to bear that would change them. And I think we've tried to remain nimble so that if something really important is noticed by anyone within the ASCO and ONS communities, we can incorporate that into changes in the measures relatively quickly, just as we did with adding the first revision to include inpatient practices when we discovered that people wanted that included in the measures.
Well, I think that the most important message that these standards try to impart to the audience is that their purpose is patient safety. And it's because even when we do everything right and according to plan in medical oncology, patients can have adverse outcomes from their therapy. And so we certainly don't want to, by not following the standards, have errors occur with treating patients. So I think that if practices and organizations focus on building these standards into their practice, they have to make it a day-to-day process of thinking about safety. Then we can really reduce the chance of errors. So although some of this may be difficult because of the need to change the way our practices are currently operating, it should be well worth it in terms of improving the care of patients.
I think in taking care of patients, it's very much a collaboration between doctors and nurses. And I think in writing these standards, it's been an absolute collaboration of equals with I hope, doctors pointing out some things to nurses which they didn't appreciate, but I know nurses pointing out many things to the physicians on the committee that we just didn't get about the patients. And I hope we continue to collaborate across disciplines with the same goal of taking care of patients. It really has been fun and eye-opening to be part of this collaboration between ONS and ASCO.
Marty and Mike, thank you very much for taking the time to share this very important message with our audience.
You're welcome. It was a pleasure to do so, and I hope that the listeners for your program will take the time to go through the standards and think about them carefully.
Thanks, Bob. It's been great talking to you, and it's always nice to talk to Marty and work on projects like this.
And please take a look at the full version of the safety standards in the March JOP issue starting on page 5S, particularly Table 4, which covers all of the details. And thanks as always for downloading our podcasts. Hope to hear some feedback at jopeditorsdesk@asco.org, or please comment on our iTunes page. We'll be back sometime after the ASCO annual meeting with another podcast interview. This is Dr. Bob Miller for the American Society of Clinical Oncology. Thanks very much for listening.